Hi, I'm Matt Binnicker, the Director of Clinical Virology and Vice Chair of Practice in the Department of Laboratory and Medicine and Pathology at Mayo Clinic. Did you know that bloodstream infections caused by bacteria like E. coli and Staphylococcus aureus remain one of the most important causes of morbidity and mortality worldwide? So being able to quickly identify the cause of bloodstream infections and use that information to tailor antibiotic therapy is important in managing patients with these infections. In this month's Hot Topic, my colleague Dr. Robin Patel will give the final presentation in a 4-part series on syndromic molecular panels and the diagnosis of infectious diseases. Specifically, she'll discuss how the use of these multiplex tests may reduce the turnaround time for identifying the cause of bloodstream infections and how this might impact antibiotic stewardship and patient outcomes. I hope you enjoyed this month's Hot Topic, and I want to personally thank you for allowing Mayo Clinic the opportunity to partner in your patient's healthcare.
Thank you for that introduction, Dr. Binnicker. My disclosures are shown on this slide. As you view this presentation, consider the following important points regarding testing. How is the test going to be used in your practice? When should the test be used? How will results impact patient management? Bacteremia is a major cause of morbidity and mortality. In patients with septic shock, delays in administration of active antimicrobial therapy are associated with increased mortality. Early administration of active empiric antimicrobial treatment may, however, be compromised by antibacterial drug resistance. Though the introduction of automated continuous monitoring blood culture systems has improved the diagnosis of bacteremia, there remain delays in identification of pathogens and antimicrobial susceptibility testing, and in the designation of contaminants. This is because all that is typically available when a bottle signals positive is a gram stain, with identification and susceptibility testing not occurring until after subcultures regrow the organism. This can impact patient management decisions, contribute to morbidity and mortality, and potentially lead to adverse outcomes such as Clostridium difficile-associated diarrhea and selection of antibacterial resistance. There are now 3 FDA-approved cleared multiplex assays that simultaneously detect a number of microorganisms as well as select resistance genes from positive blood culture bottles. The film-array blood culture identification, or BCID panel from BioFire Diagnostics, which has been available since 2013, and the Verigene gram-positive blood culture test, or BCGP, and gram-negative blood culture test, or BCGN, from Luminex, which have been available since 2012 and 2014, respectively. The BCID is a closed, multiplex PCR system that offers automated sample preparation, amplification, detection, and analysis of 27 targets. It requires about 2 minutes of hands-on time to add sample from a positive blood culture bottle to sample buffer in a single pouch, which is then loaded onto the film array system. Test turnaround time is approximately 1 hour. The BCGP and BCGN panels use the Verigene system, consisting of 2 components: the Verigene Processor SP, which provides automated sample preparation and detection of bacterial DNA in a microarray format using gold nanoparticle probe-based technology, and the Verigene Reader, which generates results based on light scatter analysis from microarray spots. The test cartridge, sample from the positive blood culture bottle, and test consumables are loaded into the processor for sample preparation and processing. The slide from the test cartridge is then placed in a Verigene Reader to yield results. The test has a hands-on time of about 5 minutes with a run time of less than 2.5 hours. These tests are largely add-on tests and are quite expensive. Therefore, their value needed to be assessed. Most studies evaluating the impact of these tests have been pre- and post-intervention studies. In other words, studies using historical controls. Results of such studies can be confounded by changes in practice occurring over time, aside from the test itself. To overcome this limitation, our group performed a randomized controlled clinical trial evaluating the clinical impact of BCID testing of positive blood cultures, along with simultaneous antimicrobial stewardship guidance. 617 patients were randomized to one of three arms: standard blood culture processing, or our control arm, which included organism identification using MALDI-TOF mass spectrometry; the BCID test reported with templated comments, or the BCID test reported with templated comments and real-time audit with feedback by an antimicrobial stewardship team. The study was performed at Mayo Clinic Rochester and was supported by the Antibacterial Resistance Leadership Group of the National Institute of Allergy and Infectious Diseases of the National Institutes of Health. There was no effect on lengths of stay, mortality, 30-day readmissions with the same organism, toxicity or adverse drug reactions, times to blood culture clearance, development of Clostridium difficile-associated diarrhea, or acquisition of drug-resistant organisms between the study groups. However, antibiotic escalation occurred sooner in both BCID groups compared to the control group, and time to de-escalation of appropriate antibiotics was notably shortest in the BCID group with concomitant antimicrobial stewardship intervention. Molecular panels for testing positive blood culture bottles have several limitations. They are largely add-on tests because conventional subcultures and antimicrobial susceptibility testing are still required, although re-identification of isolated colonies may be avoided if the colony morphology in question is consistent with the molecularly detected organism. To realize maximal benefits, these assays should be performed 24/7, adding logistical hurdles for both the laboratory and the stewardship system. In addition, the available panels do not cover all causes of bloodstream infection and may not be capable of identifying all pathogens in mixed infections, even if the organisms are included in the panel. False positive results may occur. In our clinical practice, we have observed that the BCID panel may detect organisms not visualized on gram stain or recovered in culture in 1.7% of positive BD Bactec blood culture bottles, with Candida parapsilosis and Proteus species being the most commonly involved organisms. The presence of nucleic acid from non-viable organisms in blood culture bottles could potentially explain this. It is therefore important to correlate the results of these panels with gram stain. Additionally, rare instances of species-level misidentification have been reported. For example, the Vergene BCGP assay misidentified 3 of 8 Streptococcus mitis as Streptococcus pneumoniae in one study. Such discrepancies may be assay-specific. While the Vergene assays offer customized ordering of different panels based on gram stain, this option is not available with the BCID panel. Lastly, a narrow spectrum of genes associated with drug resistance in gram-negative bacilli is included in these panels, especially in the case of the BCID panel, and therefore their ability to predict susceptibility of gram-negative bacilli is imperfect. Overall, these assays offer minimal hands-on time and sample preparation and are highly automated. They have a rapid turnaround time, enabling identification of select pathogens within 1 to 3 hours, depending on the platform, theoretically allowing for early optimization of antimicrobial therapy, as well as implementation of appropriate infection prevention and control measures. In order to enable rapid escalation or de-escalation of antimicrobial therapy, results should be reported to providers as rapidly and directly as possible, and should also ideally be communicated to an expert in antimicrobial stewardship who can work with providers to optimize therapy.